Good afternoon, everyone. We will be beginning right at 1:30. So please just settle in and get prepared. We will be starting shortly. Good afternoon, everyone, and welcome to Health Insights RISE project presents a delirium overview and the risk factor for falls. We appreciate you taking the time out of your Thursday afternoon to join us for this. We're going to get right into it. So we are using the Zoom platform today, so anybody that has not used Zoom before, all the mics have been muted, so there will be no interruptions via mic. Throughout the presentation, if you do have questions, please look to the bottom of your screen. There is a bar going across. It has a chat function on the bar where you'll be able to type in and chat any and all questions that you may have. Please feel free to chat in those questions as we're going along the presentation. When Dr. Rogers is completed with the presentation, we will go back through the questions and try to answer as many as we can with the time given. With that being said, I'd like to introduce Dr. Stephanie Rogers, who is the physician lead on the UCSF-wide delirium reduction campaign. Dr. Rogers, I'm going to stop sharing my screen so you can take over.
Okay, thank you. Happy to meet all of you virtually and excited to do this talk. I think everybody can see my screen, so I'll go ahead and get started. So my name is Stephanie Rogers. I'm a physician at the University of California, San Francisco in the Division of Geriatrics. I'm a geriatrician and an internal medicine doctor. And I'm the medical director for the Delirium Reduction Campaign. So if you want to follow me on Twitter, I tweet a lot about delirium, falls, other geriatric issues. So you can see my Twitter handle there in the lower right-hand corner. Otherwise, I think we'll just get started. We're going to talk today about falls, which is the under-recognized risk of delirium. So I have nothing to disclose. So the objectives for the talk today, first we're going to review just the basics, the definition, prevalence, incidence, risk factors, and consequences of delirium. We want to recognize the strength of association between delirium and falls and discuss how to diagnose and treat delirium. And finally, we want to recognize the impact that delirium prevention programs have on falls rates. If there's anything that you take away from the talk today, it's these major points here. So I'm hoping that I can convince you that delirium is very serious, that it's very prevalent and under-recognized. Delirium is also preventable, and it's associated with falls. And we know from studies that delirium prevention programs can decrease fall rates, and I'll present evidence for all of this. So let's start with the first one. Delirium is serious. This is my grandma, Rogers. She was a very vibrant woman. She enjoyed going to antique malls, antique shows, looking for antiques everywhere. And one of my favorite things to do was to go with her, and I would carry home boxes and boxes of little knickknacks. And when I was in medical school many years ago, I remember that she got sick. She had a cough, she had a fever, and she went into the emergency room. And the emergency physician told me that, well, she has a pneumonia. She could probably go home, or we could admit her to the hospital. Let's do this. Let's admit her to the hospital for 1 day of IV antibiotics. And if she's feeling better in the morning, we'll just send her home. And I, of course, was like, okay, sounds good. You're the doctor, you know best. And they admitted her to the hospital. Unfortunately, she did not go home the next day. Instead, she spent the first night in the hospital very confused. She was having hallucinations. She pulled out her IV. She kept trying to get out of bed. Then the staff at the hospital had to restrain her. She had to stay many days. In fact, at one point, she actually got up and fell. Luckily, didn't break anything. But what was supposed to be just a one-night stay in the hospital turned out to be a 7-day stay. And after that hospitalization, she wasn't able to go back to her home. She had spent so much time in her bed that she had gotten really weak, and she needed to go to a nursing home for some rehab. Unfortunately, also, because of that long hospital stay, she just never really regained her function, her strength, or even her cognition. And she ended up living in a nursing facility for the rest of her life. She never got to go back home, and we never got to go back and get antiques together again. And I think back on this story, and I try to understand what happens, because she was a very strong, vibrant woman, and just a short hospital stay really changed the trajectory of her life. And I realize now that I'm a physician that what happened was delirium. And that's why I became so interested in this topic. And that's why I hope I can convince you that this is serious, because delirium changes the trajectory of lives for many people. And before, it used to be thought of, oh, this is just something that happens. This is something that just happens to older people. But we know now that it's actually much more serious than that. So before we talk about how serious it is, let's just review quickly what is delirium, what's the definition of delirium. And there's a definition in the DSM V. We'll go through this kind of quickly, but delirium is a disturbance in attention and awareness. And attention is the cardinal feature. So you'll see patients kind of looking off to the sides, not really paying attention to questions. B, the disturbance develops over a short period of time. So this is an acute change in their behavior. So even if a patient has cognitive impairment or dementia, you will see a major difference in their behavior. And this will fluctuate over the day and over the week. So sometimes they may be sleeping a lot, and sometimes they may be what we call, quote, agitated, although I don't like using the words agitated. It's also a disturbance in cognition. So they're having problems with their memory, disorientation, language, those sorts of things. And obviously, these cognitive changes can't be explained by a different pre-existing cognitive disorder like dementia. This is different. And that there is evidence from the history, physical exam, or lab findings that the disturbance is a direct physiologic consequence of another medical condition, a substance intoxication, or withdrawal. So these are things like infections, different metabolic abnormalities going on, but I also want to bring your attention to substance intoxication. I hear a lot of nurses sometimes say that, oh, my patient's not delirious, I just gave them oxycodone, that's why they're confused. And I just want to bring that out, that is delirium. So sometimes when we're talking about delirium in our hospital system, I have to do a lot of education with the staff to recognize that even though you give a patient a thing and they get confused afterwards, to recognize that is delirium. So the gold standard of diagnosing delirium is using the CAM, and this was developed by Sharon Inouye, who is out of Mass Gen Hospital in Boston. And it goes over these 4 components that we just talked about. So the acute onset and fluctuating course has to be an acute change in mental state, inattention, and then they either have to have disorganized thinking or an altered level of consciousness. And I just want to spend a second talking about the altered level of consciousness. So routinely we think about delirious patients being hyperactive and agitated and trying to get out of bed and pulling out lines and those sorts of things. And that is one type of delirium, but that's actually not the most common type of delirium. The most common type of delirium is hypoactive delirium. And so this is your patient who is sleeping all day long, somewhat difficult to arouse, and groggy. And we actually don't pay a lot of attention to these patients because they have, quote, good behavior, they're good patients. But I just want to draw attention to that because it's not normal for your patient to be sleeping 24 hours a day. And that should be a trigger for you to think about, something's not right here. This person is drowsy, they're sleeping all the time. Could this be hypoactive delirium? Hypoactive delirium is obviously the most commonly missed type of delirium, and studies are increasingly showing that clinical outcomes perhaps could be worse with this type of delirium. Maybe it's because we're missing it so much, maybe it's something else, we don't really know. So delirium is serious. These are the 5 pillars we use at UCSF when we are talking about our clinical programs and how we want to do clinical care here. So under the patient experience pillar, we actually know from studies that getting delirium increases patient and caregiver distress. In fact, there was an article in the New York Times just a few years ago written by a woman who was 30 years old. She wasn't even old, and she had experienced delirium in the hospital. And it was actually 5 years later, and she was still reliving some of the hallucinations that she had. And this was very distressing for her. And I actually hear this all the time from patients and families who experience delirium. We also know that delirium increases the rate of institutionalization. So just like for my grandmother, there's one study that showed that 83% of older patients who get delirium are admitted to a nursing home or die within a year. So that's a pretty daunting statistic. 83% of older patients are admitted to nursing homes or die within a year if they get delirium. Under the quality and safety pillar, we know that delirium increases the rate of mortality. And I have another daunting statistic for you here. So the rate of mortality in delirious patients actually equals that of those patients who have a heart attack or sepsis. It's really common for hospitals to have programs for heart attacks, getting them to the cath lab fast, sepsis programs, but delirium actually has a similar mortality rate. We also know that 35 to 40% of older patients with delirium die within a year. So almost a third of patients that get delirium die within a year. In long-term care facilities, the 6-month mortality rate of long-term care residents are admitted with delirium is 25%, compared with a mortality rate of 6% for those who don't have delirium. So what that means is if you are admitted to a long-term care facility with delirium, a quarter of those patients will die within 6 months. So it's definitely a marker of something bad. Delirium also increases hospital-acquired complications. Things like falls, which we'll talk a lot about later. We know it's associated with catheter-associated UTIs and also pressure ulcers, especially patients who have hypoactive delirium and who are laying in bed quite a bit will get pressure ulcers. We have to increase the use of restraints sometimes with delirium patients. And also there is increasing evidence that shows that delirium may be associated with dementia. We know from studies that patients who have dementia and get delirium, they will have a cognitive deterioration rate at twice the rate of those who wouldn't get dementia. So it's dangerous for your brain to get delirium in the hospital. Under our people, we know that delirium is the cause of a lot of staff burnout, especially these hyperactive delirium patients. They need a lot of frequent reorientation. They can sometimes be dangerous for staff to handle. So we know they cause a lot of stress for staff too. Under financial strength, delirium increases hospital costs. One study showed that delirium increased costs by $2,500 per patient. It also costs institutions very expensive safety attendants who have to sit at the bedside and help reorient patients. This is an expensive commodity that hospitals try to decrease. And finally, under strategic growth, we know that delirium increases the length of stay. In national studies, incident delirium is associated with an increased length of stay of about 7 days. And that's actually true at UCSF. When we look at our data, we have a length of stay for most patients of 4 days, but our delirious patients stay an average of 11 days. We also know that delirium increases the rate of readmissions to the hospital. So if we look at a few studies here, this just kind of reiterates what I was talking about with delirium. So if you can tell with the red bar, those are the patients who had delirium, and the blue bar are the controls. You can tell that mortality is up in patients who get delirium. The rate of institutionalization is almost 2 to 3 times higher in patients who get delirium. And look at the difference with dementia. So patients who get delirium have about, at 4 years, a rate of 60% of delirium, or of dementia, compared to 10% of those controls. And same thing with readmissions. Readmissions are almost doubled, and the rate of readmissions is doubled with patients with delirium. I think this slide is a great slide to demonstrate what I was talking about with patients with dementia. So this is from the Archives of Internal Medicine in 2012. And this was a cohort of Alzheimer's patients in a memory clinic who were hospitalized. And it's comparing patients who had delirium and who did not. So delirious patients have the clear square, and the patients who didn't get delirium have kind of the black dot. And if you look at 2 years before hospitalization, on that y-axis is an IMC score. And the IMC is just a cognitive screen. It's like your MoCA or your MMSE. And they had about the same rate. And then if you look at the index hospitalization here, this is when it starts. And the patients who get delirium, they actually at 1, 2, and 3 years have a faster rate of cognitive deterioration. So getting delirium actually starts off quite a bad trajectory for them going forward. This is a study out of New England Journal. This is 225 patients who were 60 years or older who underwent a CABG or a valve replacement surgery. Again, on the y-axis, you see a cognitive score. This is actually the MMSE. And before surgery, they had similar cognitive abilities. 2 days after surgery, you can see that the delirious patients obviously dropped a lot. But if you follow all the way over time, out to a year, you can notice that patients who got delirium actually never fully regained their cognitive baseline. And in the MMSE, a 27 versus a 25 is actually a big difference. You know, a 2-point drop on that scale can mean the difference between living independently at home or needing more assistance. So hopefully I've convinced you that delirium is serious. Now I'd like to talk a little bit about the fact that delirium is very prevalent and it's under-recognized. So how often does delirium occur? Well, we know in medical patients, they usually have the highest prevalence and incidence, and the prevalence is usually 18 to 35%, and incidence is 11 to 14%. In surgical patients, in most studies, it's usually a little lower than medical patients, but if you look at all the studies, it's anywhere from 11 to 51%, and different surgery types have different rates. For instance, orthopedic surgeries have some of the highest rates of delirium. In ICU patients, very high rates of delirium, up to 80 to 85%. We actually consider everybody in our ICUs here at high risk for delirium, and they all get our delirium prevention bundle. And then in nursing home residents, the prevalence of delirium is about 18%. I think this is another one of those daunting statistics, but we know from studies that 50 to 75% of delirium is missed. So I hear a lot from our staff as we do education that, oh, I know when my patient's delirious, I'll be able to recognize it when I see it, but actually studies have shown that that's not true. And again, most likely they're missing the hypoactive type of delirium, but without doing formalized screening for delirium, likely everyone is missing a lot of cases of delirium. It's very common for a physician or a nurse to walk into the room and the patient can answer a few simple questions and everything can seem like it's okay. But that doesn't mean that they don't have underlying delirium. The third thing is delirium is preventable. So we know from studies that 30 to 40% of cases of delirium is preventable. And what we call here the delirium bundle is the one thing that has been proven to prevent delirium. And this is a multi-component, non-pharmacologic intervention. And a lot of these things seem common sense and very simple, but they actually have tremendous effects. So these are things like cognitive stimulation, making sure that patients are awake during the day, they have activities to do, they're oriented to where they are and what day it is. Sleep promotion, making sure that they get restful sleep at night, they're not interrupted, alarms aren't going off, those sorts of things. Mobilization, getting up to a chair for all the meals, walking outside the room, doing whatever they can to move around and get up. And then adequate nutrition and hydration. So the risk factors for delirium are things like an age greater than 80, a history of some sort of progressive cognitive problem like dementia, stroke, or Parkinson's. Functional impairment, so even having to use a cane or a walker increases your risk of getting delirium. Sensory impairment, if you can imagine that you can't hear as well or you can't see, you have blurry vision, things can get confusing very quickly if you're in an unfamiliar environment or you're around unfamiliar people. Depression and alcohol abuse are also risk factors. So those are things we really can't do a whole lot about. Those are just risk factors, but there are things that we do to patients that can cause them to get delirium. So we know that anyone who uses 3 or more medications is at risk for delirium, and I'm sure all of you know that's just about everybody, especially if you're older. Surgeries can cause it, sleep deprivation, restraints, and immobilization. So sometimes you hear staff say, well, they're delirious, I'm going to just keep them in bed. But that's actually going the wrong direction. So restraining and immobilizing them can make things worse. Urinary catheters or other tethers, so telemetry, pulse oximetry, anything that kind of tethers the patient to the bed is a risk factor for delirium. frequent procedures. So are you doing finger sticks all night long? Are you waking them up every 4 hours for vitals? This increases delirium. And then undertreated pain. So making sure that you're asking patients about their pain level and treating it adequately. So this slide shows kind of an example of the delirium bundle. So when you have a risk factor, the risk factors are on the left, and on the right are the targeted interventions. And we really teach our staff to try to identify these risk factors and then do the targeted intervention. For instance, if they have cognitive impairment, you want to write the names of all the care team members on the board and today's schedule, talk about, you know, what's the weather? Look outside. Oh, it's springtime. It's, you know, it's March, whatever you want to do to kind of orient them to what's going on. For sleep deprivation, you want to reduce bedtime noise, start a bedtime routine. A big one is avoiding naps during the day. So we, you know, get our patients up in the morning, we open the blinds, we get them going. We don't let them sleep all day. Immobility, you want them to be walking, do exercises in the bed, minimize the use of restraints and catheters. Visual impairment, we're always talking about this. You know, if a patient has glasses, make sure that they're wearing them. We try to make the clocks very big and the boards in the room so that patients can see them. Hearing impairment, so if a patient has hearing aids, that they're always in when you're communicating with them. And then having availability of amplifying devices like pocket talkers. Dehydration. We always are teaching our nurses and our patient care assistants to make sure that the water is within reach. Thirst is actually the #1 complaint in a hospital. And if you ever walk into a room, either in a nursing home or in a hospital, you'll see that the water is way far away and they can't even reach it with their hand. Even though there's possibly water in the room, it's sitting on a tray that is not within their reach. So they're not actually able to actively drink water. And this can become kind of a bad spiral too, in particular with patients who are hypoactively delirious. You have to have a staff member who's constantly encouraging them to drink because they're so drowsy, because they're so sleepy. You really need to have that person sitting there saying, take a sip of water, take a sip of water, and encouraging to keep up on their hydration, because if they get dehydrated, you're going to go the wrong direction with delirium. So this is a big study that you'll see me refer to. This is out of JAMA Internal Medicine 2015. And this is looking at that non-pharmacologic bundle, delirium bundle for prevention. And as you can see, there's 10 studies. It's a meta-analysis. And they looked at this bundle as a whole. If you do these things like sleep and cognitive stimulation and hearing and visual aid and help, does that prevent delirium? And as you can see in the studies, it did improve delirium. In fact, it gave, in the studies that did this bundle, they had a 53% lower odds of delirium, and the number needed to treat was 14. So these things seem very common sense, and they seem very simple, but you really have to do them well and with consistency, and when you do, they can have profound effects. So we only know that these things as a bundle work really well. What we don't know is when you pull out all the individual pieces, how well does that work? Are there things that you can do that have, for instance, a bigger bang for your buck, or is it the bundle as a whole? There's a few hints of what's going on. Mobilization actually has the greatest evidence behind it right now. So these are just 3 studies that looked at early mobilization and delirium reduction. One was in ICU. It reduced delirium days from 4 days to 2 days. Another study of 57 patients saw a decrease in delirium from 53% to 21%. And a final one in the ICU decreased delirium from 20% to 3%. So it looks like mobilization, and this is mobilization outside of the patient's room, can really affect delirium rates. this is a cool study about earplugs. So this was a systematic review and meta-analysis of using earplugs for sleep promotion, a very simple intervention. So placement of earplugs in patients in the ICU in isolation or as part of a sleep bubble is associated with a significant reduction in delirium. I get this question a lot. What about medications? Are there any medications that can prevent delirium? And I kind of put this all in one slide, but these are all the drugs that have been done in randomized controlled trials for the prevention of delirium. So your antipsychotics, haloperidol, risperidone, olanzapine, donepezil, diazepam, gabapentin, epidurals, ketamine, melatonin, none have been shown to prevent delirium. So medications do not work to prevent delirium. The only thing that we know that does work is that non-pharmacologic delirium bundle that we talked about. So what about treatment? Treatment is very similar to preventing delirium. The only difference is treat the underlying cause. So you really have to get at what is causing the delirium. And on the medical side, you want to think through causes of delirium. Is this an infection, a UTI, a pneumonia, any skin infections? Is it an electrolyte abnormality? Could it be a stroke? You want to kind of go through your altered mental status kind of workup when someone has new delirium. Otherwise, you do the same things that you do in preventing delirium. You want to remove unnecessary medications. So we'll talk about this a little bit later, but there's lots of medications that can cause confusion, and you want to make sure that you're looking at that list. Was anything recently changed, added? Was anything taken away? Don't forget about withdrawal from medications. Remove all the restraints, early mobilization. You want to make sure that the patient's not constipated and they don't have urinary retention. Urinary retention is actually a really big cause of delirium, and I've seen this a lot in the hospital and in the nursing home. You have a patient who's really agitated. They're moving around, they're trying to get out of bed, and it turns out that they're just not able to express that they need to go to the bathroom. And when you get them up and have them go to the bathroom, they're totally fine. But instead, the reaction from staff is sometimes like, stay in bed, stay in bed, stay in bed, and they're not assessing for these needs of needing to go to the bathroom. And then in the case of urinary retention, I always, if a patient is agitated and kind of trying to get out of bed, those sorts of things, I always make sure that the nurse does a bladder scan to make sure that they're not retaining. I've seen 2 or 3 cases this year. We've done a bladder scan. They have a lot of urine in their bladder, and you do a straight cath, and they're relieved of that pressure, and the patient goes back to acting totally back to their baseline. So don't forget about some of those simple things. And you want to avoid restraints. I know that sometimes patients are really hard to take care of, and you always want to be thoughtful about their safety and staff safety. But in particular in long-term care settings, delirium is actually 7 times more likely in patients who are restrained. So if you do need to use restraints, put them on to get through the 2, 3, 4 minutes of the active incident, and then work to take those off as soon as possible, because again, you're going to go the wrong direction if you're using restraints. I always tell my staff, think about being older, being confused. There's lots of big people in the room. They're trying to get you to do things, and now someone ties down your hands. There's not going to be a lot of a great response from any human being if that's happening to them. And so obviously always do what you need to do to be safe, but remember that that act of tying someone's hands down can have profound effects for people's emotions and also for the confusion. It can be way more confusing when that happens. Let's see. So this is actually my, my favorite slide. So this is from the Journal of Clinical Psychology in 2012, and we'll just spend a little bit of time on this. So you're going to see 5 charts here: total agitation, verbal agitation, physical agitation, pleasure, and interest. So this was a randomized controlled trial of patients with dementia who had, quote, agitation. And this was done at 9 nursing homes in Maryland. And they had a protocol where the staff was supposed to identify the unmet need. So if a patient had loneliness or depression, boredom, or discomfort, they were instructed on how to determine these unmet needs. And then if they identified the unmet need, they did the intervention. So if they were lonely or depressed, they got a one-on-one interaction, group activities. If they were bored, they got art or music therapy and physical activity. And if they had discomfort, they, were prompted to use the toilet, eat, are you thirsty, communication, pain, all of those things were assessed. So it seems very simple. Someone's, quote, agitated, and you really work hard to find out if it's one of these 3 categories. And if it is, you do the intervention. Well, what happens when you do that? You can see here that total agitation goes down by like 9 times. Verbal agitation goes down. Physical agitation goes down. Their pleasure increases and their interest increases. And this is really profound because I think in an acute situation when someone's behavior is not very good or they're agitated, we kind of look to making the patient do what we need them to do. We need you to get back in the chair. We need you to get back in the bed. We need you to go back into your room. But we neglect to really find out what is going on. Why are you upset? Why are you uncomfortable? Those sorts of things. And when you can pinpoint that unmet need and address it, it can, in addition, have some significant effects. And we talked about using medications for prevention of delirium, but what about for treatment of delirium? So let's say we have a really agitated patient. We've tried to identify an unmet need. It's not working. What about using medications? So I'm bringing up this article from the Journal of the American Geriatric Society from 2 years ago, which shows that current evidence does not support the use of antipsychotics for the prevention or treatment of delirium. It's really common, when I came to UCSF, we were using Seroquel all the time or Haldol for patients who were agitated. But actually, there's no evidence for those types of things. In fact, there's hints that by using antipsychotics, you may be increasing sedation, or you are increasing sedation. When you use those medications, you're trying to sedate a patient. That's how you're trying to get them to calm down. So you are increasing sedation, and you're perhaps prolonging the delirium. So again, you're probably going in the wrong direction. There was a recent study that was just out a few months ago that showed that using antipsychotics actually increased aspiration events. So likely, again, you're sedating the patient. They're not able to swallow as safely. And what about falls? So this is a study from Archive of Internal Medicine in 2009, and antipsychotic use was found to be associated with a 1.6 time risk of falling. So you already have possibly a patient who's a little bit active, who you're trying to keep safe, and now you give them medication that's going to increase their chances of falling. The 4th topic is delirium is associated with falls. And we've kind of already seen hints of this, but I just want to go a little bit through the evidence. So this is a study from 2009 in psychosomatics that found, this was a retrospective EHR review of 250 hospital falls. And this hospital found that that 96% of the patients who fell had evidence of delirium on chart review. So if you just think about that for a second, almost every single patient that fell in that hospital had delirium. In another study from BMJ, In delirious patients, 11% of them fell, and in non-delirious patients, 2% fell. Another study shows increased, this was a longitudinal observational study of 600 hospitalized patients. They analyzed all the risk factors for falls, and delirium was identified as an independent risk factor for falls. So increased falls in patients with delirium, 27% versus 11%. So, you know, do delirium prevention programs reduce falls is obviously the next question you would ask. So we go back to this meta-analysis by Sharon Inouye of this multi-component non-pharmacologic delirium intervention. Again, all those simple things that we were talking about before. The meta-analysis that we saw before was 11 studies. They had 4 of them had fall outcomes, and there was 1,000 patients that fell. So when you do this multi-component non-pharmacologic delirium intervention, patients have a 62% lower odds of falling. So this is the bottom half of that graph, the 4 studies that looked at falls. So not only does doing those simple things like cognitive stimulation and making sure patients have their hearing aids and that they're getting sleep, not only does it reduce delirium, it also reduces falls. So the answer is yes, delirium prevention programs actually decrease falls rates. I'm going to give an example of one here that some of you may have heard about, the Hospital Elder Life Program, also called HELP. So what is HELP? HELP is a program with a large volunteer pool to improve patient cognitive and physical functioning in the hospital. So this is actually using volunteers to do that bundle, cognitive orientation and stimulation, sleep enhancement, exercise and mobilization, making sure they have their hearing and vision aids, and feeding assistance and preventing dehydration. So in 1999, in the New England Journal of Medicine, this large randomized control trial was published. So half of the patients were enrolled in the HELP volunteer intervention, and the other half received usual care. And it found that there was a reduction in the development of delirium, reduction in the total days with delirium, and a reduction in the total number of delirium episodes. But that wasn't all, and since HELP has been in place for over 20 years, a lot of more studies have been done on this intervention. The HELP program exists all over the world now in over 200 institutions. It's a very common delirium reduction program. So we know it prevents delirium. It prevents functional decline, helps older people keep their independence. It prevents cognitive decline, and it also decreases the length of stay. Nursing home placement, so more patients are able to go home. It reduces falls, and it reduces the use of sitters. And there's been, in 2009, in the New England Journal of Medicine, Sharon Inouye, Cynthia Brown, and Mary Tinetti, who are all big falls researchers in the United States, they wrote this article about the tension regarding immobility in falls. So there's a tendency, or the old thinking was in nursing homes and in hospitals, that if a patient is at risk for falling, you just want to keep them in bed so that they don't fall. But we actually, there's increasing evidence that that is not true at all. And we know from our delirium bundle that when you do mobilization, that actually helps falls, and immobility worsen falls. So patients lay in bed, they get weaker, they think they're capable of doing the things they were before, not recognizing that they've gotten weaker, and they're more likely to fall. So this slide is just showing that there's more studies that show that the HELP program actually reduces falls. So what are the implications for clinical practice? So my view is that a failure to have a delirium program is a missed opportunity for fall prevention and a lot of other safety and just providing good care for patients. So the AHRQ correlates higher delirium rates with lower quality of hospital care, and you're going to start seeing, I think, soon more attention being placed on hospitals to pay attention to delirium. And then for long-term care facilities, the minimum data set, MDS, aims to increase delirium awareness and recognition. So now the CAM, which is a delirium screening tool that we talked about at the beginning, has now been put into the MDS. So what we do at UCSF and what more places are starting to do increasingly is to screen patients for delirium risk on admission so that you can target the prevention interventions, and then also screen every nursing shift to find, what's under-recognized new onset delirium. And the reason I often get asked the question, why don't we do these interventions for everybody? Everybody deserves great care. Everybody deserves good sleep and mobilization. And I completely agree. And I think that's an amazing future state to get to. But as we all know, resources are limited. And in particular, these interventions require a lot of human interaction and human work. And so our thinking here at UCSF is let's really target those interventions for people who are high risk and for people who actually have active delirium. So at UCSF, we use the AWOL tool, and this is a risk prediction tool. So every patient that comes into the hospital at UCSF gets this tool done by nursing on admission. And AWOL stands for A, age greater than 80, they get a point. W, unable to spell world backwards, they get a point. And O, orientation. And L, which is a little stretch, stands for illness severity. So if a patient is really severely ill, they get a point. And we use 2 as a cutoff score here. So if a patient has a score of 2 or greater, we say that they are high risk for delirium and they go into the targeted delirium prevention bundle. So this slide shows that there are some institutions that actually use age as a cutoff to determine who's going to be high risk or who's going to be low risk. And that's a pretty good way to do it. But we did a study to look at age as a cutoff tool versus the AWOL screening tool. And we found that the AWOL better classifies who's going to get delirium. So there's lots of people under 65, let's say, who would get delirium that are not getting the bundle. And there's a lot of people that are over 65 who would never get delirium, and we're using our expensive resources on them. And so we decided to actually use the AWOL tool here. And there's actually, this slide just shows there's a lot of delirium risk predictors. They're all for the hospital. I personally don't know of any in long-term care settings, but they all have similar generalizable test characteristics. So whatever you pick likely would work. And it's basically about what's feasible and accepted by your staff. We know that the 2 biggest risk factors for delirium are age and cognitive impairment. And so we really say everyone over 80 is high risk for delirium. But in addition, there should be some sort of screen on admission to the hospital or the nursing home to assess for cognitive impairment. And the Mini-Cog is a very quick way of doing that. What this is just a 3-word recall plus a clock draw. So the 3-word recall, I say to a patient, I'm going to give you 3 words. I want you to repeat them back to me. And then in 5 minutes, I'm going to ask you what they are. And I pick 3 simple things like red, car, and ball. And then I make sure they can say it back to me. And the next thing I do is I say, I want you to draw a clock, draw a face of a clock, put all the numbers on it, and make the hands say 10 past 11. And this is always a very interesting one, and you'd be surprised. So in the last few weeks, these are 2 examples of clocks drawn by patients who, to me, seemed very normal in conversation. Nothing seemed off. So this one's slightly wrong. The hands are supposed to say 10 past 11, and they don't. And this one was really interesting. I kept trying to redirect the patients. I'd say, you know, put the numbers on the clock, put the numbers on the clock, and this is what the patient came up with. So it's always a reminder to me that although patients can compensate well, answer questions easily, that you really need to do formal assessment to see what's going on. So by using age and cognitive impairment, that's a decent way to predict who's going to be high risk of delirium. And then you always want to be on the outlook for patients who develop delirium in the hospital. And like I said before, 50 to 75% of the time, nurses and doctors totally miss it. So you have to formally screen. And we at UCSF use the NuDisc, and there's lots of delirium screens. We picked the NuDisc because it's feasible and quick to do for nurses. And basically, we have our nurses who work 12-hour shifts. They, at the end of their shift, towards the end of the shift, they think back on their interactions with the patient during the day, and they rank the patients based on these behaviors. Were they disoriented? Did they have inappropriate behavior, inappropriate communication, et cetera, et cetera? And if they get a score of 2 or greater, then we're saying they have possible or probable delirium, and the physician should be notified and they should be assessed. And then the physician needs to address the underlying cause, find any medical causes, and then we work together as a team to do the delirium bundle. And like I said, there's many other delirium assessments that can be done. CAM is the best validated. There's a CAM ICU, there's a shorter CAM, there's a FAM CAM, which is you ask family questions. There's all kinds of things out there, and there's it's still up for grabs as to what is the best and what is the most feasible, but lots of people are doing different things. So if someone ends up being high risk for delirium, or they have active delirium on any of the screens that you do, you want to make sure that you do the delirium prevention bundle. And number one is, if they have delirium, treat the underlying cause, the pain, the dehydration, the constipation, the infection, whatever it is. Number two, review and remove deliriogenic medications. And all of the patients in our hospital, when they screen positive for high risk for delirium or active delirium, the pharmacist is automatically triggered to do a review of their medication list. So things like Benadryl, benzodiazepines, steroids, opiates, whatever it is, they take a look at those medications, they review the indication, and they speak with the physician. You know, does this patient really need Benadryl? Is there something else we can use for itching? Can we use Sarna cream? What else can we do that won't be as deliriogenic? And then we work together as a team, nursing, patient care assistants, rehab staff, doctors, everybody, to do the non-pharmacologic behavioral intervention. So are they wearing their hearing aids and glasses? Do they get cognitive stimulation during the day? Are they mobilizing out of their room? Are they sleeping well at night? All of those things. So to summarize, I hope I've made the case that delirium is serious, that it's prevalent and under-recognized, that it's preventable, and that it's associated with falls, and that delirium prevention programs can actually decrease fall rates. And I have a lot of acknowledgements. There's a lot of people that help me learn and help us make our program better here at UCSF, but the number one person is Vanya Douglas, who who I say is really the brains behind our delirium reduction campaign. I'm kind of the type A person behind the campaign, but he's really the brains. And so now I will leave it up to all of you, and we'll kind of go through the questions and see if I can't answer some of the questions for all of you. So I'm gonna stop sharing my screen here and take a look at the chat. I'll just go back to the beginning. Please type in your questions if you have any questions.
Just a quick note real quick for those of you that just if you look over in the chat bar, we included the evaluation link for the CEUs. This needs to be completed in order to receive your credit for the CEU. So if you could just take a moment to click on that link before or after you're done chatting in your question. Thank you.
So I'll just start at the top of the questions. So how is delirium preventable and how can it be reversed if diagnosed early? Hopefully I have convinced you that that simple delirium bundle is what you need to do to prevent it and reverse it as quickly as possible. A question from Leah here. So delirium comes before signs of a dementia. So commonly, yes, that can be a sign that a patient has underlying cognitive impairment. Remember, there are two different things. So patients with dementia have an increased risk of getting delirium. And if you have dementia and get delirium, your cognition is likely to get worse. But in some cases, patients can have no cognitive impairment and get delirium. It happens in younger people. It happens in all kinds of people. So although they're related, we're still in the research area kind of parsing out what's going on there. From Michael, what is the cause of delirium or contributing factors? So we talked a lot about the risk factors, cognitive impairment, age, hearing and vision issues, having infections, all the underlying conditions. The cause of delirium, or at least the underlying mechanism, is still unknown. They think it happens more in aging brains because of there's less neuro connections, and so there's a stressor can have a more profound effect. And they think that possibly has something to do with cytokines and inflammation, but the jury is still out on why delirium happens and how it happens in a physiologic sense. So I don't know, and I'm not sure that anyone knows, but that's your million-dollar question if you can figure that out. How about having a window to outside? Excellent, yes. It's always great to put patients by windows that get natural sunlight. It helps with their sleep-wake cycles so that they know it's daytime when it's daytime, and they know that it's dark when it's dark. So that's a great idea. Can you explain NNT? Sorry, number needed to treat. So in that meta-analysis, NNT stands for number needed to treat. And in that meta-analysis that showed that non-pharmacologic delirium bundle prevents delirium, what number needed to treat means is how many times do you have to do this intervention for it to pay off for one person. So when that had a number needed to treat of 14. So for every 14 people, what that's saying is in general, for every 14 people that you do the delirium bundle on, you will prevent delirium in one person. And a number needed to treat of 14 is a really good number. Usually other medications, when you're doing randomized control trials, have much higher number needed to treat. Can you have access to my slides? Yes, I think they will be giving you access. So you use both the AWOL tool and the NuDisc tool. Yes. So the AWOL, remember, is the risk predictor. That's done one time on admission. And once you're deemed high risk, you're high risk forever. And you need to have that prevention bundle in place. And then the NuDisc, that screens for active delirium. So perhaps someone comes in not delirious, but 4 days later, they're delirious. That NuDisc is there, and it's done every shift to try to pick up delirium. Remembering that we miss delirium most of the time, and so we're doing this formal tool to be able to catch it. When you say it can be reversed when diagnosed earlier, how early is early? Well, I don't have any direct studies on this, but obviously the best thing is prevention. Any delirium can possibly have a bad effect, possibly a long-term effect on a patient. So obviously, the first step is prevention. And then getting to it early is always better. The more prolonged the delirium is, the higher risk of having long-term cognitive problems, things like pressure ulcers from laying in bed, those sorts of things. So when you say how early, as early as possible is better. So delirium is acute or chronic depending on underlying cause and treatment. So delirium by definition is acute. It's an acute change in mental status. Delirium can be chronic. There are many cases where delirium can last months. In a general sense, most cases are acute and they leave and it stops, but it can be chronic. And it doesn't really, I mean, it could depend on the cause or it could not. So, you know, if you're not treating the underlying cause, if you're not treating the infection or the constipation or the sleep-wake abnormalities, you're going to cause delirium to be chronic. And that's why it's so important to go through the underlying causes in a systematic way so that you can figure out what's going on and reverse it. You suggested to do the new disc every shift. For how long usually? We do it the entire time that they're in the hospital. Even if they were negative on the new disc for 10 days in a row, we know a lot of things that we do to patients in the hospital can cause delirium. We wake them up at night, we make them lay in bed, they get constipated, all these things. At any time, patients can develop delirium. So every shift that they are in the hospital, we do the new disc screen. Okay. I think that's all the questions. Feel free, if you have any more, to type them in quickly. I'm happy to answer them. Are there any formal programs for applying this to skilled nursing facilities? Paula, you're actually kind of touching on a new area. So in general, there is not a lot of studies about delirium in nursing homes. We actually don't know what the right screening tool to use, what risk predictor is the best, how the bundle works. The one thing that we know, you know, if you go back to my study on unmet needs and addressing unmet needs, that's one of the biggest nursing home studies. So we, in geriatrics and in medicine, extrapolate what we know from hospitalized patients into the nursing homes currently. But there's a big push in the delirium research realm to really take a look at skilled nursing facilities and rehab facilities. So I think just recently in the last 10 years, delirium has been seen, you know, before it was seen as this thing that just kind of happens to people, but now it's being taken more seriously. And so the research community is really stepping up. So I think you're going to see a lot of things coming out about skilled nursing facilities in the next 10 years or so. How often should we screen in nursing homes? I would recommend probably every shift, if you're at least twice a day. Obviously, you want to catch things early. Once a day wouldn't be bad, but I think if you truly want to try to catch it as soon as possible, I would think probably at least every 12 hours. If you do something like the new desk, it really takes 10 seconds for the nurse to fill out because they just think back onto their shift. They don't have to ask the patient to do things, answer questions, any of those things. They just think back about behaviors and they put in a score. So it doesn't take that long. Some of the other screening tools take quite a bit of time, and you've got to ask the patients a lot of questions. And so I think you have to really think about what you want to use. Can you say more about the clock test? Why is this important and what does this tell us? So yeah, we talked about the Mini-Cog, and I showed you those clocks that patients had drawn that were abnormal. You know, this, like I said, I've been surprised many times by patients who act completely normal. They answer your questions appropriately. They're very pleasant, but then you ask them to draw a clock and they can't do it. They do things like drawing those circles, or they get the hands mixed up, or they can't right, 1 through 12. And the clock test is just a really simple way to do a quick screen for cognitive impairment. You obviously don't put any diagnosis to that. That's just a quick screen to tell you, hey, something's up here. You know, perhaps my patient doesn't understand complicated instructions because they can't draw a clock, or perhaps they're not going to remember to press their call light. It just gives you a hint that cognition is not normal. It could be delirium. It could be somnolence. It could be dementia. It could be a lot of things. But what it does tell you is that their thinking is not clear, and whether that's acute or chronic, we don't know, but that a lot of the education that you do, the instructions that you do, you know, hey, press your call light before you get up. If a patient's not able to draw a clock correctly, they're probably not going to remember those instructions. And they're probably not going to remember complex instructions like, hey, we're changing your beta blocker from 2 times a day to 1 time a day, and we're upping your dose of your losartan from this to this. They're not going to be able to do those types of things. So that clock draw gives you a hint that you may want to get family involved, and you may want to come up with a different system of reminding patients. Any other thing I could ask a patient who may not have seen or knows how to read a clock? Yeah, there's a lot of good screening tools out there. If you're thinking about delirium in particular, you know, we talked about at the beginning that the cardinal feature of delirium is attention. And so there's a couple studies that are a couple quick tests you can do to test someone's attention. And one is spelling world backwards, or having them say like the months of the year backwards. And a lot of people think, you know, it has a little bit to do with memory, but it mostly has to do with attention. And if you can't go backwards, you know, December, November, October, etc., if you have decreased in attention, you forget where you are in that going backwards thing, and so you will miss that. And so a good screening test for delirium is testing this cardinal feature, which is attention. So either spelling a word backwards, world is commonly used, or saying the months of the year backwards. Just a comment related to the clock test and the way that the question is worded, 10 past 11, I see potential issues with the increase of digital clocks and regular clocks with numbers and face may be used less frequently, at least for the newer generation. Just a thought. Your thought is a common concern of many geriatricians. Thought that the millennials and everybody else coming up is they in general won't know how to use a clock. So I think we're gonna have to get creative and find a new way to do this. I think we're okay for now with our baby boomers, but yes, in the next 20 years, they're probably gonna have to find something else. Any other questions?
All right, not seeing any new questions come along. Just like to say thank you, Dr. Rogers, for spending the time with us and opening yourself up for questions and that presentation. We really appreciate it. If by chance a question does come up that you'd like to have Dr. Rogers reach out and answer, you can see either myself or Donna, our emails are listed there. Please feel free to send the email to us and we can get you Dr. Rogers' contact information. Okay? Thank you very much for everybody. Once again, a reminder in the chat box is the link for the evaluation for the CEU. So make sure you get that completed before you head out, and write down the emails if you need further questions or anything. Thank you again. We'll leave this open for a little bit, about 5 more minutes or so that you can do that. Thank you again, everyone.